Trace, do you want to go ahead? All right, so it's my pleasure to welcome Dr. Venkatesan Chakrapani. Venkatesh is a senior public health research fellow at the School of Public Health at the Postgraduate Institute of Medical Education and Research. He's also the chairperson and founder of the Center for Sexuality and Health Research and Policy, CIRA, which is an NGO devoted to improving the health and well-being of sexual minorities. And his research and CIRA in general has focused on improving and understanding the sexual and mental health of MSM and trans populations, which he is considered to be a leader in the area in India. He will be talking to us a little bit about that, particularly the focus of stigma and syndemics within the context of HIV among MSM and transgender populations in India. So welcome, please welcome. Thank you.
Good afternoon, everyone. Thanks for the introduction. So, in my talk, as Trace has said, I will focus on stigma, syndemics, and HIV risk among men who have sex with men and trans women in India. So, this is just an outline of my presentation. So, I will briefly introduce the HIV epidemic among MSM and trans women in India, and then a little bit about HIV risk, especially condom use among MSM and transgender. And again, the connection between syndemics and HIV risk among these populations, and stigma and HIV risk. And then the interconnections among all these three, stigma, syndemics, and HIV risk, and what can be done further in relation to research and the implications for programs. So that's going to be my talk. So I hope to finish it in 30 minutes. So HIV epidemic in India can be said as a concentrated epidemic because it is concentrated among particular populations, like what our National AIDS Control Organization calls as key populations or core HRGs, high risk groups, core high risk groups they call National AIDS Control Organization. Okay, some numbers are not coming up here. The HIV prevalence among MSM, the yellow one is the MSM. So 4.3% among MSM, and it is 7.5% among trans women. So when you compare that with the general population, the HIV prevalence is only 0.26%. So it is 15 to 30 times higher among MSM and trans women in India. So the last one is actually the injecting drug users. It's about 9%. But of course, the numbers wise, the MSM and transgender population are relatively more when compared to injecting drug users. If you look at the HIV prevalence trends among MSM and transgender, so initially there was a decrease from 2008 to 2011. There was a relatively steep decrease, but from 2011 to 2015, these are government data. So you can see it's plateauing. The HIV prevalence is plateauing. There is no significant decrease in HIV prevalence. But the HIV program among MSM and trans women have been there for the last decade, more than 10 years. So what is wrong? So is there anything wrong in the National HIV program? Because National HIV program is primarily focusing on outreach education and the distribution of condom and promoting that condom use. So that is where the point which I'm going to discuss, the syndemics, whether is it possible that we are missing something, whether we need to focus on, say, mental health and alcohol use and violence which are happening among MSM and trans women. So that's why the need to focus on syndemics comes.
Thank you, Tish. Can I ask a quick question?
Yes.
Is there any idea what's causing that initial sharp decline for transgender women between 8 and 11? Is there any, does Nico or you have any idea of what's called, like it's a halving of that percentage? Any
Oh.
idea?
Okay, so but this is being recorded. So
You can pass if you need to pass. Yeah.
So yeah, after that. So but anyway, it's not a secret. It's primarily because of addition of some other sentinel sites in which there is actually not that much risk among trans women. So it's because more of that dilution effect, because we are adding more number of sites where you don't have that much high risk, where there are not trans women who are, for example, engaging in sex work, then you are going to actually get decrease.
So it's a
So
completely
it's-
sampling
yes.
kind of
Yeah.
thing. Yeah.
Okay. Okay, so most of you might know that the term MSM is a behavioral term. It means if you want to define MSM, it's men who have sex with men. That's the definition. It's the term itself is the definition. So it's a behavioral term because the idea is World Health Organization taught it is not the sexual identity or the sexual orientation which is leading to HIV risk, but it is actually the unprotected anal sex. So from that angle, they wanted to use the term men who have sex with men. And again, in India, if you like here, like for example, in Western countries, people may identify as heterosexuals, but in India, we don't have any specific term for heterosexuals. So nobody actually are heterosexual in the sense like they don't identify as heterosexual. None of the Indian languages, they have the term which is equivalent to heterosexual. Even though there are technical terms now being coined, many people are not aware about it. So the point is like if a man is going to have sex with another man, he may not think he is homosexual. Because he may think, okay, I'm only the insertive partner, I'm the active partner, I'm behaving like a man, I'm inserting. So it is only, for example, I have seen my patients telling me, they will tell like, I had sex with a homosexual. So that's how they will tell. So which means that this person is masculine and insertive, and somebody who is feminine and insertive, he is the homosexual. Okay. But in spite of that, there are specific identities. There are some indigenous identities. For example, this is a simple classification according to the socio-economic class. So people from the lower socio-economic class, MSM, they may identify themselves as, for example, one of these, Kotis, double-deckers, and Pantis. So Kotis are men who have sex with men who are feminine and who primarily take up the receptive role. And they call the masculine partners who insert them as Pantis. So Panti used to be mainly as a label given by Kotis to somebody who is inserting them. But nowadays, both the Panti as well as the double-taker term, which used to be labels, now it is becoming like an identity. Even the term MSM is becoming an identity. So if you go to an NGO working with MSM, they will say, oh, I'm an MSM. So it's becoming an identity, even though it is supposed to be a behavioral category. And of course, there are also people who identify themselves as gay or bisexual. But again, majority of the even Kotis or double-deckers or Pantis, they may eventually get married to a woman, and many of them may then actually they are engaging in bisexual behavior. Okay, again, transgender women. There are several indigenous identities of trans women in India. So the commonly known term maybe for other people is Hijras. So Hijras or Kinnars, those are the terms which are primarily used in North India. But there are other terms which are used in other parts of India. For example, Tirunangai is the term which is used from my state, Tamil Nadu. And in some other states like Maharashtra, Karnataka, they use different terms, Jogtas, Jogappas, and Shiv-Shaktis, for example, in the state of Andhra Pradesh. Of course, some people may also call themselves as transgender. A person can identify as Tirunangai, and the person may also identify as a transgender or trans women. Okay, briefly about the legal status. So, Section 377 is actually a British legacy, but nowadays people are arguing like, don't blame the British for everything. They have actually changed their law. You are not changing it. You keep blaming them, but you are not changing. It's in your hands. So I don't want to say it is mainly because of them. So actually, the section 377 it criminalizes any act which is what they call not natural, which means they mean oral sex or anal sex. So even between maybe men and women who are married. So this section 377 is not actually in relation to homosexuality. It's technically it is against particular sexual acts, but what happened is like people actually virtually thought like it is against the homosexuality. Okay, so Delhi High Court in 2009 they decriminalized the consensual sex between same-sex adults, but again Supreme Court it reversed the judgment of the High Court, so it is again then it became decriminalized. But that's the story in relation to the homosexuality within courts. But if you come to the transgender people, it's the Supreme Court has made a progressive judgment that people have the right to self-identify as whatever the gender they want. So that happened actually in 2014. So the Supreme Court said that it's in brown color, like you can see, gender identity forms the core of one's personal self based on self-identification, not on surgical or medical procedure. So the court allowed self-affirmation of gender identity. So anybody can go and state that I'm a man, woman, third gender, transgender. So whatever term they would like to use, that can be there. So even in the national identity card nowadays, they allow like transgender. Okay, so but even though there is decriminalization of homosexuality, there are same-sex couples who are living together and who are getting married. So for example, this is marriage, of course, legally not recognized, but still people are getting married like this. This happened in 2015 after the decriminalization. So there is still resilience among the community in spite of the non-acceptance legally. Okay. So actually, in the National AIDS Control Program, the focus on MSM came in 2007. So after nearly like maybe 10 years after the initiation of the National AIDS Control Program. And in only in 2012, the National AIDS Control Organization explicitly states transgender. Otherwise, it was transgender people were included under MSM. Even in 2007 guidelines, they were included under the MSM umbrella. If you look at the national goals, so it is very ambitious, like no new HIV infections by this year, 2017, and 100% voluntary and regular HIV testing. 100% cannot be voluntary, but that is the national goal. Okay, so if you look at the global goals, there's one thing called 0, 0, 0. So 0 new infections, 0 discrimination, and 0 AIDS-related deaths. This is supposed to happen by 2030, but of course, again, an ambitious goal is having 0 discrimination, at least in the healthcare settings, by 2020. So this also shows the importance of the need to focus on stigma. Okay, so if you look at the coverage data, again from the national program data, among MSM, the coverage is 65%, and among transgender people, it is 35%. This is last year data. Again, I don't want to go into the detail of actually the size estimate itself, which is a controversial area, but according to the government's own data, the coverage is still very inadequate, especially among trans people. Okay, so we have seen briefly about the HIV epidemic scenario, and coming to the condom use. So we have data for MSM for several years, but for Hijras we only have last year, the government data. So if you look at the MSM data, the condom use is increasing obviously, but still it is only 55%, which is obviously inadequate. And if you look at the Hijras, again, similar percentage, like about 52% among regular partner and to 65% among paying or casual partners. So again, the condom use is still not adequate. So in spite of like 10 years of a national program. Okay, so now coming to the syndemic conditions and HIV risk. So I will briefly tell what is syndemics, but so there are some psychosocial health problems which increase the risk of HIV, like inconsistent condom use. This has been shown to be associated with alcohol use, same depression and inconsistent condom use, and self-stigma and inconsistent condom use. So there have been separate studies, individual studies, which have documented those. But in my study, like I also documented, that was a survey among 300 MSM and 300 trans women. So our team, we have documented the occurrence of certain psychosocial health problems, which includes alcohol use, depression, and violence victimizations. So we have shown that it is clustering, it tends to cluster together among these populations. So that co-occurrence of particular psychosocial health problems, and if they are going to synergistically increase the risk of, say for example, HIV, then those are called as syndemics, because they are synergistic epidemics which fuel each other. So that's the concept of syndemics. So okay, so if you look at the prevalence of the syndemic conditions, again mostly this data is mainly from my study, which is in brown color. I told about the 600 people survey. But I have also included data from some other studies. So the depression level is about, say, 50%, 24 to 55% among MSM, and trans women it is 42%, and problematic alcohol use is around 15 to 40% among MSM, and 37% in trans women. And violence victimization, physical or sexual, is 35 to 50% among MSM, and again it's very high among trans women. I cannot able to now tell the disaggregated data how much of that is actually forced sex, but this is combined. But you can see nearly everyone in the last 1 year, they have experienced either physical or sexual abuse among trans women. So in the same study, this is published one, we have shown that as the number of syndemic condition increases, the sexual risk also increases. So then you can see like no syndemic condition, 1 condition, 2 condition, 3 condition, there's a gradual increase in the percentage of people who are in the sexual risk category. So this is a simple bivariate analysis, but we have also shown in multivariable analysis, as the number of syndemic condition increases, they are more likely to be in the sexual risk category. Okay, so we have seen about syndemic conditions and HIV risk. Now coming to the stigmas. So this is one of my earlier studies. This is I think 2007 or something. So this shows a model, a structural violence model that among MSM, they face various forms of stigma and discrimination at various settings from different the actors. For example, from family members. Which one is laser? Okay. Okay. Let's go. Okay. No, the laser point. Oh. It's okay. It's okay. Anyway, tell because it's not visible from here. So, so basically, it summarizes the various forms of stigma and discrimination faced in the family setting, in the healthcare setting, from the police, and from the general public. Maybe, for example, this is just an example from that, but this is actually from a recent study. This is just 1 year back. Like there's a small qualitative study which I did among MSM. So this also found that, for example, among Kotis, they are facing physical and sexual violence from the thugs as well as from the police. Okay, so there's also blackmailing and extortion of money, mainly from police. So you can see, for example, police take our photos and get our numbers. They demand money or sex. So this is especially cohorts if they are going to stand in the cruising sites. And if cohorts in sex work, they are going to stand regularly because they are in sex work and that is the regular hotspot. Then the police will know they are actually engaging in sex work and then they will be demanding money. Again, the stigma faced by MSM and transgender women is coming from various sources of identities. So it is not only in relation to the sexual orientation or gender identity, but also in relation to being in sex work or being HIV positive person or suspected to be a HIV positive person or being from lower socioeconomic status. So it's a mix of all these. So there are multiple stigmas or what is called as intersectional stigma. So that also then we need to take into account when we are going to decide about the stigma reduction programs, which one we need to focus on and how we can focus on all of this, which one of that will be important. So those are some of the things. So this is a qualitative study. It's a small study. Like there was a 5 focus groups among different categories of MSM. Just I'm not showing a lot of qualitative data, just a few quotes. But basically, we have shown by what is called as process tracing. So you can, because in quantity most often we cannot able to show the causal association, but in qualitative study you can, by particular techniques, a causal pathway can be demonstrated. So using that, we have shown that people who have experienced discrimination, so there is going to be increase in the self-stigma, and then because of that, there is going to be a depression, and in relation to the self-stigma, because I have self-stigma, I feel bad about being a homosexual or a trans women. So I may want to self-isolate from my family members. Because in India, like it is more like a collectivistic culture. It's not like of course we cannot say this is individualistic culture and collectivistic culture, but we are more in relation to like more often, even after marriage, people, men, they live with their own parents. So that because of but for in relation to the same thing, the collectivistic culture, people want to avoid bringing shame to their family members. So either they self-isolate themselves from the family members, or sometimes they may be evicted by the family members because they are acting in a feminine manner, which may bring shame to the family. So either way, they are losing the family support. So the social support is lost and family support is lost, which is also contributing to the depression. So that is how there is a connection between the discrimination experiences, self-stigma, and depression. So this is a qualitative data, but in my study, a quantitative study also, among the same study which I talked about among 600 people, we have shown the connection between MSM stigma and transgender stigma with depression. And we have also shown that the effect of stigma on depression is mediated by resilient coping and social support. So we have qualitative and quantitative evidence for the connection between stigma and depression. And if you want to look at the connection between stigma and sexual risk, again, first qualitative data, again from the focus group studies which I mentioned. I cannot go through each and every part, but basically, depression can lead to unprotected sex in 3 different ways. One is depression can lead to alcohol use, and alcohol use before sex, unprotected sex. Another is what is called as a cognitive escape. So people may know about condoms, they may even having condom with them, but they may not be using that because of a variety of reasons. And another is because of depression, people may have fatalistic attitudes. Say anyway, like nobody is respecting me, and anyway I'm going to die. So that kind of attitude can also lead to unprotected sex. So again, we have evidence for all these from the qualitative study. So some people may think depression means people may not be sexually active, right? So, but even in our study, we asked that question, but of course people responded, like for example, yes, some depressed persons don't have sex, but many MSM try to get out of it by focusing on getting more sexual partners, especially if the depression was due to love failure. for example, people have told me like, okay, in front of my ex-partner, I have to show I am happy and I am getting a lot of partners. So that's one reason they have a lot of partners, and that's also may result in unprotected sex. Okay. Okay. So that was the connection between the stigma and sexual risk from the qualitative data. Now there's at least one study which we have shown from Chennai, like the connection between stigma and condomless sex. Okay. So again, from our recent pilot study, me and Dr. Kesha's study, it's a pilot OCG among HIV positive MSM, about 119. We have also found preliminary evidence for the efficacy of a community level stigma reduction intervention, which is improving safer sex behaviors among HIV positive MSM. So what I have shown is there's a connection between stigma and sexual risk, both from the qualitative data and the quantitative data. Okay, so in spite of all these stigma and discrimination experiences, not all MSM or trans women, they engage in unprotected sex or they become depressed. That is because of the resilience and social support available to them. So resilience, the ability to bounce back from depression, and if they have adequate social support, family support, or support from their friends, then they can bounce back very easily. Okay, so again, in the same quantitative study, we have demonstrated that people who have high resilient coping or high social support, they are less likely to be in the category of unprotected sex. Like inconsistent condom use category, they are less likely. Okay, so we have seen about the condom use, about stigmas, about syndemics. Now, how all these are connected, or whether they are connected. Okay, so because that has been my one research focus. So what I'm now planning to do in the next maybe couple of years, I'm thinking about is about testing a model. So one is we need to know how these syndemics are produced. So we talked about syndemics, and there is one actually framework from USA, Stahl et al. They have talked about production of syndemics among urban gay men. I have looked at it, but it's primarily about social and cultural marginalization of gay men within the cities, which lead to the syndemics. That is the overall framework which they have given. So I think for the Indian context, yes, but we may need to modify that because of some cultural specific issues. But also that particular framework is in relation to primarily urban gay men, so urban and gay identified people. But you have seen like people have like from A to Z, the different kind of indigenous identities, and there are some cultural aspects and subculture within those identities. So we need to take those into account, and we have also seen it is not just one stigma, not just MSM stigma, transgender stigma, but there are multiple stigmas. Okay, so this is the model which I am planning to test. So, so multiple stigmas, whether they lead to the syndemics, which in turn increases the HIV risk. Of course, I am not showing all the possible arrows back and forth, just the main arrows I am showing. And so these are, so the first one, the multiple stigmas, that is based upon what is called as intersectionality framework, and we also have some empirical evidence that if there are two or more stigmas, then there is a high risk of getting, for example, at least one syndemic condition, depression or alcohol use. But we do not know whether multiple stigmas actually can lead to syndemics. Okay, so and again, whether the social support and resilient coping can moderate or buffer or mediate, we don't have any idea like how that is going to act. So that also needs to be tested. But from the minority stress model point of view, social support and resilient coping may act as a buffer of the effect of stigma on depression. But here we are talking about multiple conditions. So based upon these proposed models, there are a lot of questions which can provide avenues for further research. So one is whether stigmas, they lead to HIV risk primarily through syndemics. How to measure intersectional stigma? So for example, if somebody is discriminated, whether the person is discriminated based upon the transgender identity, or the person is also a sex worker, or person is suspected to be HIV positive. Okay, so that's another thing. Like in presence of multiple or intersecting stigmas, what is the relative contribution of different stigmas on syndemic conditions or HIV risk? And is there any specific combinations of syndemic conditions that increase HIV risk? And whether syndemically oriented interventions can reduce HIV risk. So again, this I am conducting a pilot study. So there have been enough call for such syndemically oriented interventions from available empirical data and also expert commentaries. And finally, like whether the combination of stigma reduction and syndemically oriented interventions can reduce HIV risk better than interventions that focus on either one of those. So those are the questions for which we need to find answers. I haven't seen even from USA any syndemically oriented interventions so far published. So I think, but people have called for such interventions. So yeah, I would also like to thank my partner agencies and my supporters and funders. So with that, I conclude. So thank you very much. Any question now? Africa. Yeah.
Wonderful presentation. Thank you. Thank you for being here at CIRA.
Thank you.
I was wondering, and I don't know if you mentioned this earlier, about the healthcare system and how available treatment is for treatment as prevention or PrEP.
Yes. Yeah, of course, I did not talk about that. I have been doing some studies on new HIV prevention technologies, including PrEP, HIV vaccine, and rectal microbicide acceptability. So we have already, for example, published the acceptability of PrEP among MSM. Of course, many of them, they are willing to. Now, PrEP is also available from some private practitioners. But officially, like from the Indian government, they have not taken a position on providing PrEP. So, of course, I was also telling Dr. Trace that my focus, of course, here for the talk, I am focusing primarily on psychosocial kind of interventions, but ideal would be more like a combination. So both psychosocial intervention plus biomedical. Okay, so I did not, because then that will complicate too much like my talk. I thought so I did not put that deliberately, but I have been working on that also for the last 5 years, like acceptability studies. You can find my publications. Yes, I think it is important, like in the so another is regarding the treatment as prevention. The National AIDS Control Organization, so far until now, they have a CD4 cutoff, a criteria that if your CD4 is less than 500, then you are put on antiretroviral treatment. But now, maybe this year, sometime, they may remove that criteria, and as per the WHO recommendation, they may recommend antiretroviral treatment for everyone who is tested HIV positive if they are willing. So yes, the treatment as prevention also, I think it should come up.
But I guess in terms of the PrEP, I think you had said that it's available kind of conceptually, but in practice it's not uptake, like it's not widespread.
It's not, because many MSM and trans people or even other key populations, they are not aware about PrEP. There is one PrEP demo project going on among female sex workers in 2 sites, I think funded by WHO primarily. But NACO so far has not started any PrEP demo projects among MSM or trans women. So far, even though they acknowledge they are important populations, and the condom use level is not increasing, and HIV prevalence is also plateauing. And actually, in some sites in India, it is actually increasing, the HIV prevalence.
Can I ask just,
Oh, sorry.
Yeah.
just the other part of my question was for people who know they're HIV positive, if
Yes.
they're willing to go and identify and be in treatment, is that free?
Yeah, that's
It
free.
is free.
Yeah, it's free. Yeah.
I was wondering, given the importance of stigma, how strong are the regional differences? Just like here in the United States, being MSM in rural Alabama is very different from here in Connecticut or the areas of New York. Are there very strong regional differences that would impact the level of stigma people experienced?
Okay. Regional differences. Yeah, for example, maybe in relation to trans women, I can talk about that. For example, in the North India, the Hijras, the general public, they may see them as sacred beings. So the blessings or cursings, they will think, okay, it's going to be effective. So there is some kind of like fear and respect for trans women in the North India, but in South India, for example, the state where I come from, Tamil Nadu, so there is no such belief. So there are some regional differences in relation to stigma and discrimination, but in relation to MSM, I think mainly across India, because there it's more like masculinity among men is valued. If somebody is feminine, then you are suspected to be homosexual. So it's primarily the stigma against the femininity. So that is actually common across India. So that's why, like for example, in my studies among MSM, we have two different set of stigma measuring scales for MSM. One is those who say they are feminine, so we will be administering what is called gender non-conformity stigma scale. And for people who say that no, we are not seen as feminine by other people, then we are using the traditional sexual stigma scale. So it's mainly in relation to the feminine nature, like there is stigma across India.
Thank you.
Sorry that I don't know about the culture too much. I'm just curious that for this MSM, do they have the cultural pressure to get married, to have kids? And for those people who are really identify themselves as MSM, do they disclose their MSM preference to their family member? Because you did mention about the sister having married, and then as soon as that person move out, it should be fine. Does that really influence the whole family, or how the family structure to be seen from the outsider? And you also mentioned about alcohol use, but did you have any experience about their recreational drugs?
Okay, first one in relation to now
The
I forgot the
family.
first question.
The culture of family.
Okay, so one is about whether they disclose their sexuality to their family members. Okay, so most often they don't disclose, and even quote-ly identified people, they get married to a woman, and so of course because of we cannot only label that as a pressure from the family, but sometimes I would say, based upon our qualitative research data also, I would say some proportion, not all, they may willingly get married to a woman, then they can be seen as normal by other people, and they also avoid the guilty feeling of, because of you, there is no family lineage is not going to stop. So there is the sustenance of the generation, like there is a name which has to be carried out. So that's one reason, like they would like to get married. And what was the other thing? So
Just substance use, but carry on.
yeah.
For the wife who get married to the gay man, did you have any experience around that?
Yeah, there are one or two qualitative studies which have been published on that by other researchers. So it's usually they don't disclose to the spouses, but after the disclosure, of course there have been anecdotes of divorce, but couple of people, some people may stay together, may try to accept, may try to understand, because some feminist point of view, they may argue that now these women have nowhere to go. So this person will be, even if there is a divorce, then the blame will come on that lady. that person, and she will not be having support from the in-laws family or from the parents' family. So from that point of view, like it is, people argue that even if the women has said that I accept you or living with that person, that is not real acceptance. It's more like forced to live with that person. Okay, so but there is limited research on about the disclosure behaviors of MSM to their spouses. But of course, we have documented the risk behaviors with the women partners, including the spouses. So I have my studies also, but there's little study on this disclosure and the spousal reactions and all those. So another one, yeah, I also wanted to add, see one HIV positive gay man. He's openly HIV positive gay man. So he told that when he disclosed his status, HIV status to the family, of course they naturally maybe they wanted to know how he got the HIV infection, and when he disclosed his sexuality also, then the family members told that don't tell other people that you are having sex with men. Just tell, okay, you got it from some sex circle. Even if you are HIV positive, we agree, you can stay with us, but if you are going to tell this to other people, get out of our home. So the stigma in relation to then the sexuality issues are much more higher than that of in relation to HIV. Okay, so another one in relation to the recreational drug use. So according to the national data, only about 3% of MSM they inject recreational drugs. So this is national data, but that is primarily among MSM who are from the lower socioeconomic status group, because the national data is mainly from them. But if you look at some cities, in some cities there are party drugs which are being used. For example, in Mumbai, in Delhi, there have been drugs, recreational drugs which are reported. For example, the one famous drug now in Mumbai is like what they call meow meow. So meow meow drug. So like that, you can hear like different kind of drugs being used in gay parties, and of course these are recreational drugs. But there may also be, because of say the depression or other things, people may also be using drugs. For example, among Hijras in Delhi, it has been well documented that a significant proportion of Hijras in Delhi, they also inject drugs, not necessarily for recreation purpose, but because they are also maybe depressed. So this actually a separate rehabilitation program for Hijras who are injecting drugs. Yes.
Once again, thank you very much for that.
Good afternoon. I'd like to first thank CIRA for their continued support of the International Visiting Fellows Program. Last year proved to be a very successful collaboration between Vina Pillay and Kaveh, who I believe is not here today, and appreciate the continued support of the program. I'd like to introduce Dr. Iskandar Azwa. He is Associate Professor of Medicine and Infectious Diseases at the University of Malaya in Kuala Lumpur, Malaysia. University of Malaya is the national flagship university of Malaysia. He is currently the director of the HIV Clinical Care Unit, Outpatient and Inpatient Services. He's the former head of infectious diseases for the University of Malaya Medical Center. And he opened the first ever LGBT sexual health clinic in Malaysia, which he'll be sharing with you some of those details today, and is currently leading the effort to implement PrEP for MSM and the trans community in Malaysia, virtually single-handedly. But he is spearheading that effort right now, and is leading Malaysia into the future of PrEP. So I'd like to introduce you to Dr. Azwa.
What did I do? I need help already. Sorry about that. So what do I do?
That's right.
Okay.
Yeah.
Thanks very much, Jeff, for that very kind introduction. I'm very, very excited to be here. You know, it's not every day you get invited to Yale, so certainly from an invitation perspective, thank you very much. And it's an honor to really speak in front of you. And I thank CIRA and Jeff for inviting me here today to speak with you. And I'm very excited to meet with you after this, if there are possibilities to. Now, my background's slightly different. I mean, you could call me an infectious disease physician, but so I started my training very much in the UK, both undergraduate and postgraduate. But in the UK, if you want to do infectious or HIV training in particular, especially in London, you have to do it by sexual health. And so I started infectious diseases and then gradually moved to sexual health and HIV, and that's what's often done in big cities in the UK. So I'm a sexual health physician by training, and have continued to try and do some sexual health from my initial training in the UK. However, when I moved to University Malaya, when I returned home to Malaysia in 2009, a lot of my work got caught up in HIV-related work. So I've been doing a lot of HIV care and treatment work recently, until recently, where I ventured into HIV prevention, clinical and research work. So the outline of my talk today, I'm going to talk briefly about the HIV epidemic in Malaysia, my initial experiences of trying to set up a sexual health clinic and the successes and the failures associated with it. I'm going to briefly talk about my current research projects and what's led me to PrEP research currently, which is my main area of focus. And it's really in the infancy stage. And certainly I would appreciate learning more from what the US has currently been doing. And what I think there are the research gaps in pre-exposure prophylaxis in Malaysia. So for those who don't know where we are, this is Malaysia. Can I touch that? No, there's no. Okay. So we're in Southeast Asia. We're stuck between Thailand and Singapore, and a lot of people still don't know where we are. So I felt the need to put it on a map. We're made up of West and East Malaysia. We have a population of about 30.5 million in 13 states. We're a multi-ethnic group. We're made up of Malays, Chinese, Indians, but Malays are the predominant ethnic group within the country. And Islam is the most widely professed religion within the country, although Christianity and other religions are widely practiced. Now, Malaysia's received a lot of bad profile in the press. If you've been hearing about it, we've lost a Malaysian airline in the past 2 years. We've had that dramatic shutdown of one Malaysian Airlines not too long ago. And the political situation is not great at the moment. But we survive and we strive and we carry on. Now, the HIV epidemic in Malaysia is, to date, and this is based on the number of notifications up to 2015, have been about 108,000 to date. It's very much concentrated within key populations, so very much like in India. So injecting drug users initially, but also in men who have sex with men, female sex workers, and transgenders. This is data reported by the Integrated Biobehavioral Surveillance, which is done by the Ministry of Health, showing increasing prevalences across most groups apart from injecting drug users, including men who have sex with men, from about 7.1% to 8.9%. The transgender prevalence there is probably lower than what we expected, although in 2014 they managed a sample size of greater than 1,000. Jeff has done some really exciting work in this area. He showed the HIV prevalence to be at least 11.7%, so higher than what has been reported by the Ministry of Health. The number of cases have peaked in 2002, and sort of have been on a steady decline until about 2010, when they've started leveling off. And what started out initially as injecting drug use epidemic, we're now moving towards that of a sexually transmitted epidemic. So much so that in 2015, 78% of the cases were attributable to sexual transmission. And this is largely due to successes within the harm reduction program, which was undertaken by the government. Now, in terms of sexual transmission, if you break that down further, it is still predominantly a heterosexual epidemic, but amongst those heterosexual epidemic, you see it comprises largely clients of sex workers, so it's not broken down further as such, and so that data needs to be teased out further. But what you can see by the orange part of the bar chart is that the number of cases attributable to new HIV cases due to men who have sex with men is increasing as the years go by. And this is reflected across most countries in Southeast Asia, where men who have sex with men are really the predominant risk group. There are very high HIV incidences across Southeast Asia. And looking very much like what the epidemic looked in countries like the USA at the beginning of the epidemic. STI notification rates are very poor in this part of the world, as it is in other parts of Southeast Asia. There are only 3 reportable STIs in the country, and they're mainly syphilis, gonorrhea, and chancroid. And chancroid we've hardly seen for a long, long time. So really, the most common sexually transmitted infection there is gonorrhea. Now, my initial experience of having come back from the UK and into to Malaysia was largely at the time, with increasing epidemiology of sexual transmission, there was hardly any services providing integrated sexual health care, and that was very, very unusual. I think even in that setting, Thailand had loads, Singapore had an established service, but Malaysia had really, really nothing at the time. Primary care at the time was well placed to provide sexual health services, but they weren't really doing anything very much at the time. So with a group of people who were working within the NGO sector and getting funding largely from a foundation from one of the states of the one of the states within the northern part of Malaysia, we managed to get some funding to sustain a clinic for about 2 years. Now, having come back from the UK and wanting to sort of duplicate the model there, perhaps that was overambitious at the time, in providing similar services that were available in the UK at the time. So we wanted a confidential, non-profit making clinic offering treatment and treatment and screening of sexually transmitted infections and HIV. And that was the leaflet of the clinic. I can't remember why we used Caucasian faces, and I can't remember why we used a boy and a girl. There was no huge direction at the time apart from wanting to fill a gap. And these are partly the drivers. Apart from having nothing at the time, we wanted to address the increasing role of sexual transmission driving the HIV epidemic. In order to reduce the stigma associated with any of the key populations accessing the services, we wanted to combine it with reproductive health care. And that largely incorporated family planning services to generally increase accessibility of the clinic so that key populations wouldn't be stigmatized coming to the clinic. It had to be community-based and not part of a hospital, because we wanted to bring out services to the community and make it more accessible. And we wanted to address sensitivities around sexual health in a confidential and sensitive manner. So our target groups were wide, and probably once again, maybe that's one of the lessons learned as well. We often forget that youth are disproportionately affected by STIs, and certainly this was a group that we wanted to target, apart from the key populations which are traditionally associated with high HIV risk in this part of the world, so them being female sex workers, clients of female sex workers, transgenders, men who have sex with men, refugees. So we were able to provide some of these unmet sexual health needs. Certainly in the Asian setting, a lot of the key populations do not just access services, they have to be brought to the clinic by a key worker, and it's a very common theme which is present in this part of the world. But we were able to provide some what the community thought were novel services. So non-occupational post-exposure prophylaxis was a very new concept at the time. Certainly there was provision of post-exposure prophylaxis for needle stick injuries within the hospital setting, but provision of non-occupational, so of following sexual exposures, was a very new concept. but widely accepted if offered. Vaccination against certain STIs, so hepatitis B and HPV, and opportunistic STI screening. Now, and I'm sure a lot of other places within the Asia Pacific are very similar. STI screening largely relied on a syndromic approach to STI management, which involved basically the client presenting with syndromes and the doctor who sees the client essentially treating the client for all the possible pathogens. There are pros and cons of this system, but it does away with the concept of asymptomatic screening of STIs, where the bulk of STIs lie. We were able to provide a lab-based detection of STIs and point-of-care diagnostics using microscopy, and we were fairly strong in terms of psychological support and counseling services. Just very quickly, in terms of the clients that accessed the clinic, we were open for about 2 years. About 1,336 patients accessed the clinic in that time. 70% were MSM, 16% heterosexuals, and interestingly, 50% of that were clients of female sex workers and 12% transgenders. The sex worker group was particularly difficult to engage. And we managed to look after 120 HIV positive patients under regular follow-up, of which 60% were foreigners, with a 90% retention rate and a very, very high HIV testing acceptance rate. Sadly, the clinic closed. The Ministry of Health, it was hoped that the Ministry of Health, and it was agreed initially that they would take on the services, but they did not. But nevertheless, with any intervention that you have attempted, even though it didn't work at the time, there were lessons to be learned. And some of the lessons, particular to this part of the world, was to start small. Don't be so ambitious in trying to replicate a model and adapt it to the setting that you are in. Community engagement was very, very essential, and I think something that we did well in engaging through the key populations, and we were able to shape and provide services according to the needs of the community. We could have monitored and evaluated our services better, and that remains a key lesson which is learned. And if we were to do it all over again, I believe a social enterprise clinic model is certainly better than one which is relying on commercial social responsibility funds. And there are key population-friendly clinics already within the community, and really is trying to identify those. And maybe work with those rather than setting something up from scratch. And different key populations have different needs, and rather than what we had tried to do was to try and address everything in a more broader sense. A one-size clinic probably doesn't fit, and maybe addressing the needs of the individual key populations would have been better. Transgenders in this part of the world are basically obsessed with just one thing, and one thing mainly. And if we were to replicate the model for a clinic for transgenders, offering hormone administration and monitoring services certainly would be right there on top. There are very few services in KL which offer that, and they're certainly interested in these services. Everything else then stems away from that. And one of my initial objectives was wanting to move away from a syndromic approach of STI management. And if we wanted to do that, we really need to think of cheaper and more effective, cost-effective ways of trying to screen for chlamydia in asymptomatic clients, especially within MSM patients. Because in MSM patients, you can screen them practically from every orifice. You have the pharynx, you have the rectum, and you have the urine. And really, this is not cost-effective in a resource-limited setting. And discussions are undergoing and how to move this forward, because really no chlamydia is tested or is tested very poorly in that part of the world. So even though we weren't successful, but the Ministry of Health went on to use our model somewhat to at least build on some STI, what they called STI client-friendly clinics, and currently there are about 23 clinics nationally, so all was not lost. So there was some movement from there. And this is data from about January 2016, where some key populations are accessing the services, even though it is a Ministry of Health setting, but which have adapted themselves to key populations. In terms of research, we had wanted to do a bit more research, and certainly there was potential had it survived longer, but nevertheless we were able to do a bit of research. And this is looking at a biobehavioral and prevalent study of HIV, syphilis, and hepatitis B in high-risk men who have sex with men. This goes back, so somewhat old data done 2013, which at the time was submitted to IAS. So looking at 229 men who fulfilled the inclusion criteria, of which the mean age was 26 years, and you have this concept which is also present within other parts of Asia. 85% identified as homosexual. So even though these were men who had sex with men, not everybody identifies themselves as homosexual. They had to be high-risk men in order to fulfill the inclusion criteria, and by definition needed to have unprotected anal sex in the past 6 months. The pooled prevalence at the time was about 17.5%, and syphilis also was very high, at about 16.2%, but hepatitis B relatively low at 4.8%. And looking at some of the sexual behaviors, now some Malaysian MSM would say that their sexual behavior is very different from them of their Caucasian counterparts. But in reality, it's not very much dissimilar. So 91% use the internet to find casual partners in the 6 months, so a lot of you accessing the internet. 10.5% ever had sex with female partners, and this is very particular to this part of the world, having had female partners and having had sex with female partners. And a lot of non-condom use, mainly with primary partners. Now, current research, I'm going to just skip that because it's probably not relevant. And sort of leading up to my current research, or what I'm currently trying to collaborate with Jeff in Malaysia. Now, PrEP has had a very, very slow movement in Asia, and in particular in Southeast Asia, apart from what's been happening in Thailand. And this was a review in Journal of the International AIDS Society in 2016 by Irina Zablotska, who really is leading on a lot of the PrEP implementation within New South Wales, Australia. So the review basically showed that there was awareness amongst about PrEP within the Asian Pacific setting is very low, but on the other hand, a high proportion of MSM who are aware of PrEP are willing to use it. The key barriers include mainly poor knowledge of PrEP, very limited access to PrEP, non-existent HIV prevention programs. So in Malaysia, a lot of money is invested into HIV treatment and care. So first-line antiretroviral treatment is provided for free, but very, very little is provided by the government for HIV prevention. And a lot of the work is expected to be done by non-governmental organizations, which really rely on external funds for their ongoing work. High cost of PrEP, even though there's access to generic Truvada, and stigma and discrimination against key populations. Now, men who have sex with men, they're naturally discriminated, naturally, because I'm not talking about in Asian settings. I mean, in our setting, as long as you perhaps, if you don't, although they're a stigmatized population, if you don't really flaunt the understanding, if you don't flaunt your homosexuality, people often leave you alone. And so there is stigma and discrimination, but not as much as you probably expect. And also restrictive laws. I mean, criminalization against homosexuality, we inherited the same laws from the UK, and even though the UK has dispelled with those laws, we continue to have those laws. But very few people actually brought to the criminal justice because of acts of homosexuality in reality. In terms of clinical trials and demonstration projects that have been implemented so far within the Asian Pacific, really only Thailand has really made some progress in that area. But novel approaches to PrEP implementation, especially community-led models of care, have been of interest, certainly within the Asian Pacific setting. So this is looking at the review in 2016, really from the Malaysian setting, very little being done at the time, but a lot being done just below in Thailand. So you had already about 4 or 5 demonstration projects already at the time in Thailand. So part of my work into HIV prevention has largely been advocacy, and in realizing that HIV pre-exposure prophylaxis is a huge game changer in the era of HIV prevention, and maybe standing aside and wondering why everybody else is not sort of within my setting, why everybody else is not sort of clued up with this. Things really started working in August in 2015, where with discussion with the community and Ministry of Health, PrEP was included in the National Strategic Plan to end AIDS for the next 15 years. And this was led by Ministry of Health. This was then followed by a very exciting meeting in September 2015 of a regional PrEP consultation led by the Asian Pacific Coalition of Men Who Have Sex with Men in Bangkok. And this really stimulated some inter-country and intra-country discussion of what needed to be done across the countries within Asia Pacific, or the fact that more needed to be done, and tried to discuss solutions on how to increase access within the region. In March 2016, we undertook our first online PrEP survey within MSM in conjunction with International HIV Alliance, and in May 2016 there was our first intra-country national PrEP consultation. We formed the first PrEP working group in May 2016, and in order to try and speed things up, because we realized that not having national PrEP guidelines was potentially a barrier, we completed the first national PrEP guidelines. And we had our first Asian PrEP implementation meeting in Bangkok in January 2007. In January 2000, so during this time there were ongoing negotiations with pharma. In Malaysia there is no Gilead presence. There hasn't been a Gilead presence until recently. So generic providers of Truvada were able to provide, or at least provide TDF FTC at a much reduced cost. Currently it's priced at about US $35 and has been running at about that level for about a couple of years. But this we felt was still too high, and ongoing negotiations have taken place to try and reduce the price further. What is good is that it looks like by the end of the year the price reduction to about US 12 a month is likely to happen, and so the cost issue around PrEP is probably not going to be an issue by the end of the year. In February 2007, following a proposed multi-site demonstration project funded by UNAIDS, a site assessment by WHO and an independent consultant from the Thai Red Cross was undertaken, and subsequent a protocol refinement was hoped and is due by the end of the month. So the national consultation on PrEP was really is also where things started at a national level, which a lot of stakeholders were able to engage discussions in pre-exposure prophylaxis. You must understand that the Ministry of Health prior to this they weren't excited about PrEP, and mainly because they were always of the opinion that the community wanted them to finance PrEP, and that is very much how we all would like it, certainly at a financial level and at a national PrEP provision level. But really what we wanted was more guidance on how the Ministry of Health could provide support. It need not be financial, but it's just some clear guidance, and certainly from the HIV/AIDS sector. What they did recommend, however, was more operational research and a PrEP demonstration project to study the feasibility of PrEP implementation in key populations. They emphasized non-Ministry of Health settings because at the time Ministry of Health settings did not have the means to charge patients for antiretrovirals, and so we were ideally placed, being in the university hospital setting, to try and at least start a pilot project. So just going back to some of the ways in which we tried to move the PrEP agenda forward within country level. This was back in April 2006, where we did an online PrEP survey within MSM, looking at mainly PrEP knowledge and acceptability, and the factors associated with willingness to use PrEP. We conducted the survey in about 990 men. The survey lasted for about a month, from March to April 2016. We collected the usual data such as demographics, sexual drug use behavior, attitudes towards PrEP, and then we performed factors associated with willingness to use PrEP. So of the 990 men who were eligible, 44% had ever heard of PrEP. So still not a great amount. You would have thought that, these group of people who are highly connected through the internet, more would have heard of PrEP. 39% of the sample were willing to use a PrEP when we used a 5-item scale from a 7-item scale adapted from Tim Holt. And the factors which were associated with willingness to use PrEP were very much similar to the factors that were represented in other studies. Now, looking at that a bit more, 44% had heard of PrEP. Most had heard of PrEP from the internet, and very little from mainstream newspapers and magazines. So very little discussion around PrEP outside the internet. When asked specifically the question of whether they were likely to use PrEP if it was made available in Malaysia, 49.9% said very likely. And willingness to pay, now on the background of a sample population of which earned about USD 500 a month, 36% were willing to pay for PrEP, 48% weren't sure. For those willing to pay for PrEP, 89% were not willing to pay more than $50 per month. So if you capped it off at around that much you'd be able to, so still if if clients still had to pay for PrEP, it wouldn't be too much of an issue if you capped it off at that. Looking specifically at the sites where clients preferred to access PrEP, community-based organizations always came out on top, so 22%. This was followed by private clinic and subsequently 18% in government hospitals or art treatment centers. And then there was the issue around post-exposure prophylaxis. Now, interestingly, although this was not a focus of the survey, 71% had heard of post-exposure prophylaxis. Sorry, 71% had not heard of post-exposure prophylaxis, and only 2% had ever taken post-exposure prophylaxis in the past 12 months. So very different, perhaps, from the setting of post-exposure prophylaxis use in the United States. And looking at factors specifically in a bit more detail on the willingness to use PrEP, the Malay race was more likely to use PrEP. So this concept of identifying yourself as straight or heterosexual was less likely to be associated with willingness to use PrEP. Having more than 2 anal sex partners in the past 6 months, as was having heard of PrEP and confidence in practicing safer sex, and ever having paid for sex was associated with willingness to use PrEP. In the qualitative study, so from this, participants who had answered the questionnaire, online questionnaire, were asked whether they wanted to participate in a qualitative study. Very few people were willing, but 18 clients or participants subsequently took part in focus group discussions held at a community-based organization. And some of the themes that we looked at specifically were awareness of PrEP, perceptions of PrEP, access to PrEP, motivations and barriers to the use of PrEP. So looking at this in a bit more detail, in small groups, but in about 18 patients in 3 focus group discussions, there was generally a positive perception of PrEP. However, there was a greater need for PrEP education. PrEP was thought generally to provide a second layer of protection, and they would use PrEP in addition to condoms. So not as a replacement of condoms, but in addition to condoms. And the MSM community felt that PrEP also was a good prevention method for serodiscordant couples, whether you were MSM or heterosexual. The reasons for using PrEP cited were additional layer of protection. Most would use PrEP on a daily basis and would stop taking it when they ran out of their seasons of risks or when they were not sexually active. Reasons for not using PrEP that were cited, mainly fear of side effects, cost at the time. Many expressed that although the government should make it available for all, some cited a lack of confidence in government clinics in providing PrEP, largely for concerns around confidentiality and fear of discrimination, in particular with accessing government health services. In terms of ways of trying to facilitate PrEP, clients favored an online form of accessing PrEP via applications or specialized websites with deliveries directly to them, followed subsequently by government and community-based clinics. most participants were willing to go for regular HIV screening for PrEP. Some felt that promoting PrEP for everyone would reduce stigma associated with being MSM within the Malaysian context, but some highlighted the concerns around the misuse of PrEP as a potential party drug or as a form to use a drug to allow oneself to have unprotected sex. But ultimately, participants wanted more information about how to use PrEP, when to start, when to stop, how it worked, the side effects, where to get tested for HIV. There was a general lack of information around, specifically around pre-exposure prophylaxis, and they wanted access to providers which were specifically MSM friendly, where they could access PrEP. And as previously mentioned, the distrust around government clinics. And this was a quote: "If it is the government doing it, I have absolutely zero confidence that they will handle this well." So this leads us, and I just conclude in the last couple of minutes or so, on a PrEP pilot overview. This is a pilot project which is funded by UNAIDS and also a bit of funds from the Global Fund. It has been aptly named the Indie Project, so investigating in a neglected disease, evaluating HIV PrEP for prevention of sexual transmission in Malaysia. So this was just replicating the HIV prevalence data within the MSM population and low levels of condom use with the most recent partner. This is data from, once again, IBBS, and reporting prevalences of as high as 22% within the setting in Malaysia, in Kuala Lumpur in particular, as high as 22%. So we've partnered with the Malaysian AIDS Council. We had proposed initially, based on funding, to screen 150 HIV negative participants at high risk of HIV infection over a 12-month period, and we're using generic Truvada-based PrEP. 3 sites have been proposed. Our site, which is a HIV treatment center in a university hospital, a private clinic with a high HIV STI caseload, and we wanted to look at the model of trying to access PrEP for clients in a community-based organization. It's a very simple study. There's no, we weren't at the time looking at anything too complicated. We just wanted to get something rolling out. And with most pilot projects, looking at the key objectives of acceptability, feasibility of the use of PrEP during a 12-month study period. The study population was initially meant to be targeted towards the MSM population, but because of sensitivities expressed by the Ministry of Health and looking at with the MSM population, and because the other key population that they expressed that was of interest for them to look at was HIV serodiscordant couples, we coupled this patient population together. And further work is also being done by Jeff in the future, looking at transgenders and sex workers subsequently. So it's a 2-phase study, the site assessment and subsequent demonstration project, which is planned for September 2017. So there were secondary objectives. We want to look at adherence, retention, client satisfaction. We want to look at change of sexual behavior over the course of the project, and record any side effects and associated with PrEP uptake, and determine HIV and STI prevalence at baseline and incidence, and how everything comes together in terms of trying to link everything together. There are other areas which are currently being proposed, so this is still in the inception phase. We were looking to see if it was plausible to collect and store blood samples for both drug levels and looking at HIV resistance testing based both at baseline and breakthrough HIV infections, and also to identify and inform the most acceptable PrEP service delivery model and the role of a CBO in the provision of PrEP. There were concerns mentioned by one of the site assessors in terms of how we would best try to exclude HIV infection at baseline, and in order to try and resolve this, we will also had further discussions with one of the providers, Elia, to see if we could do qualitative point-of-care viral load testing at baseline to see if there was any incremental benefit of using a point-of-care viral load at baseline above that of the proposed fourth-generation HIV test in ruling out HIV infection. So 3 sites, about 50 to 70 participants per site, and using 3 different, very different treatment sites. So one's a treatment center, one's a private clinic, one's a CBO. The study drug, initially we had wanted to look at client-based PrEP, but we're moving away from that. I mean, one of the game changers, which we were very excited about, was ongoing negotiations between pharma company, and this is a generic provider, over several periods, over several months, led to provision of free PrEP for the purposes of the study. And it's not very usual in that part of the world, so we certainly were celebrating successes around that. And as mentioned earlier, the price of generic Truvada is likely to fall further within the next year or so. So eligibility criteria very much has been what used in previous PrEP studies, able to provide written informed consent to be HIV negative on a 4th generation HIV antibody test, antigen antibody test, have a normal renal function and evidence of substantial risk of HIV infection during the past 6 months. And this was categorized as having had unprotected sex with a HIV positive partner, unprotected receptive inserted anal sex with a casual partner of unknown HIV status, any bacterial or viral STI, use of drugs for sexual pleasure, having used PEP in the past 6 months, buying or selling sex. And exclusion criteria was simplified to exclude those with current HIV infection, signs or symptoms of acute HIV infection, a creatinine clearance of less than 60, current use of nephrotoxic drugs, or unable to attend follow-up clinic appointments for the duration of the project. We were not going to exclude hepatitis B surface antigen positive patients. We thought this would provide an ideal opportunity of using PrEP within this setting. And certainly those who are hepatitis B surface antigen positive, we would just continue the use of PrEP indefinitely in these patients. So HIV testing imperative, baseline 1 month, 3, 6, 9, 12 months. In the Asian setting, STI prevalence and incidence has been suggested, but not particularly emphasized on. We wanted to look specifically at this, both syphilis and also chlamydia and gonorrhea. And if we had a choice within the MSM population to look at sites where we expect high rates of infection, so in this case the rectum. We divided the tests into mandatory and optional tests, and that was largely due to funding. We wanted to simplify the whole demonstration project. We didn't want to complicate things, and basically just use tests which were mandatory rather than optional. And using questionnaires at various different time points, looking at sexual behavior, adherence, acceptability, and perceived stigma. So some of the key recommendations from WHO and the independent consultant from the Thyroid Aid Cross Center are as on the slide. So we have some prevalence data within MSM, but very little HIV incidence data. And they thought it would be good if we looked at that, HIV incidence estimates from sites currently testing. The importance of recognizing HIV infection, this is where a lot of you can advise us appropriately. Whilst initiating PrEP, there were debates on whether we should be using HIV point-of-care viral load. Was a 4th generation test sufficient at baseline? Or what they had suggested was using a 3-drug regimen at baseline for all, and then dropping the 3rd drug to a 2-drug regimen a month after initiating. Apparently this is where WHO is moving towards, although we've not heard of anything of that beyond the meeting. Clearly define the target PrEP population and post-project access. It would be nice to allow patients to have PrEP in accordance with good clinical trial practice after that, but that's all down to funding. We hadn't planned to continue the project beyond 12 months, but it was suggested that we should at least in the bare minimum look at HIV infection status at 6 and 12 months. And some of the challenges with scaling up PrEP within the region largely is the lack of experience. And certainly within the Asian Pacific setting, this is very much a new service provision. We're learning from our neighbors and we're learning from the rest of the world, and we're bound to get it wrong. But that shouldn't really dissuade us from at least trying. We should be innovative and think of new service delivery models, not just from either a treatment center or from a primary care setting. Certainly, as mentioned previously, the community-based model is a very attractive model to move forward because they have the trust of the community. From Thai studies, they've shown that clients are willing to pay for PrEP if delivered at an affordable price. And community advocacy and leadership still is very much very, very low within the PrEP, within driving PrEP access within this country. And this really needs to, it can't be reiterated, more of it needs to happen. The community must be driving this rather than anybody else. Form strong partnerships between academia, Ministry of Health, CBOs and clinicians. So, it's a very exciting area to work. If we haven't, it's a new service delivery, but really involves multiple stakeholders. The current state of PrEP in Malaysia is not great. We certainly don't have any funding of PrEP in public programs. There's increasing availability in the private sector, and we have some provision out-of-pocket PrEP at reduced costs in the center that I'm at, and recently more PrEP is being provided in a very disorganized manner from Ministry of Health primary care clinics. But it comes down to cost. They're expected to pay for it currently. This is my last slide, and I'm just going to conclude what I thought was areas of future research within the Asia-Pacific setting. I mean, the role of PrEP certainly within the national strategy has been mentioned, but it does not define it further. So that really needs to be better defined. We need to think of more practical and more cost-effective ways of trying to deliver PrEP services. So learning from Thailand is certainly one area that one country we look towards. Efficacy of PrEP in other at-risk populations, we're starting with MSM. We felt there's a great need in that, but certainly the transgender population is a population which needs to be looked at equally. The role of HIV self-testing in PrEP service delivery models are emerging across some demonstration projects across Asia, something worth looking at. And the interplay of chemsex, HIV risk taking the role of PrEP. Chemsex is becoming an increasing problem within the MSM population certainly in Malaysia, and that needs to be looked at how it is fueling new HIV infections. And of course the role of new agents, which we have less access of, such as TAF and injectables as PrEP. So, and I think with that was my last slide. Apologies if I went over time. And I'd like to thank Jeffrey once again, and of course CIRA for inviting me here today. Yes, please.
Hi, I'm a non-physician, I'm a nurse practitioner provider of PrEP in a community-based organization on a mobile van in the city of New Haven. I have a lot of resistance about other providers wanting to provide PrEP. Do you see the same problem?
Very much so. I mean, certainly within the ID field, the infectious disease physicians don't feel it's their place to provide PrEP. I mean, they're very much centered around treatment provision for the HIV positives, and to get their heads around PrEP also is extremely difficult. So currently there is no interest, or very little interest amongst ID physicians. Their focus is largely within treatment, and so I think it's just a matter of work in progress. They are sort of, ID physicians within Malaysia are considered the person with the greatest rights or access to antiretroviral therapy. So it's only natural that they lead by example. So that's the way I see it anyways. Or at least some primary healthcare physicians who are already involved in provision of ARVs. They could also potentially lead. On the background already, also you must understand within Malaysia that the country is also struggling with provision of antiretroviral treatment for all. So we've moved towards universal treatment, but not all settings have the resources to be able to do that. And so there is this ongoing discussion about how can we provide PrEP for preventative purposes when we're already struggling to meet and provide ARV for people who are in need of treatment. And that debate will continue, and I don't think there's a resolve at this stage. I think the bigger picture really is, I think in terms of the overall picture is that the number, you use PrEP right now, the number of infections that you'll prevent later on will prevent less people becoming HIV positive. But that outlook is not shared by all. And I think it's still very much a narrow to focus approach by the Ministry of Health and also a lot of my colleagues within the infectious disease field. Yes.
Thank you very much for being here at CIRA and for this sweeping presentation. I'm sure you may have covered this in the presentation and I missed it, but I mean, first of all, I wanted to say, I'm sure you're aware of this, but there are certainly parallels in our experience here in the different parts of the U.S.
Yeah.
There's much more concentrated effort in some places to introduce PrEP in innovative ways, like in New York City and in states that have getting to zero campaigns where PrEP is a major feature. But we're struggling with a lot of similar issues, and one of the things that's happening in Connecticut that CIRA is actually supporting is looking at PrEP, the use of PrEP navigators, or people who really work more attentively with individuals who are taking PrEP or interested in taking PrEP to keep them connected. And that might be something that you're trying in Malaysia, or because I know one of your objectives in research is to find more effective models.
So we use that to navigate clients who get diagnosed positive within the community-based organization, the NGO sector. And certainly as the hope is that as PrEP gets rolled out, that you could apply that same model of using navigators to access PrEP in settings. Yes, so certainly that would be a consideration for the future. We just need to get more people on board and to get in the buy-in. It's as Jeff said, it's really, it's a very lonely thing. Very few people are driving this, and within Malaysia, and it's. I think the first thing is to get the buy-in from more people. But yes, certainly using PrEP navigators to access PrEP would be certainly something we could look to.
And just the number of providers of PrEP in Malaysia, we talked about it. There are maybe 7, give or take, physicians actively prescribing PrEP.
So it's very, very small.
In a country of 30 million.
That's right. 30 million is so.
The other thing we've done in Connecticut is we have a Connecticut website for PrEP providers. So you can go to the website and find a PrEP provider. And so a lot of people will call and then you can arrange them. The other question I have is who pays for the creatinine clearance? That is one problem I have. Especially if they want to be anonymous.
Yeah, so I think, outside, so there are very few centers providing PrEP at the moment. And so certainly in our setting, they would be expected to pay for that. The creatinine clearance is not expensive,
No.
so it's not really, it shouldn't really dissuade patients from accessing PrEP. I think the concerns which were raised in the quantitative and the qualitative studies was more the cost of the drug at the time. But yes, no questions were specifically raised in the surveys around the lab monitoring.
Because we also have a lot of electronic monitoring now.
Yes.
People are scared to go into the EPIC or whatever electronic medical record you're in,
Right.
to get it in there for the drug or the monitoring and the HIV testing, so that it becomes a problem.
Right.
For some people.
Yes.
It's a stigma of, why am I getting tested? And is that in my record? And especially young people, because it appears on their parents' insurance. And I have a horrible time with that. Because you can't do it anonymously.
Yes. Of course.
I wanted to comment on that, and I should introduce myself as a pediatrician before I say this, but you mentioned that being youth is a risk factor, being a youth is a risk factor, and then the eligibility is 18 and over. And I just wonder about sexual debut and the age of sexual debut among young MSM, and the idea that the meeting online in the majority of these cases, and age differences between young men meeting older men and things of that nature, they are at risk, and there needs to be. It's difficult in this country. We haven't properly addressed it in this country. Those getting on PrEP tend to be older, but I just pointed out that it really is a concern.
The problem in Malaysia as well, HIV testing, you're not meant to, it's technically illegal to perform HIV testing if you're below age 18. Now there's no sense, you could think about it all you like. If you're at risk, you should be allowed to have HIV tests. But it really, the Ministry of Health have remained adamant on this position for now. There needs to be work with them about trying to change this, because it's really nonsensical. It assumes that people do not have sex below the age of 18, which is completely, nonsensical. But if you're going to do a project, and if it's going to get Ministry of Health, sort of approval, you have to adhere to some okays by their standards. Even if it doesn't make complete sense, it just makes it very difficult, and you're not going to capture that bit of information, which, as you say, is extremely important.
It would be the same here, doing the study here. It would be 18 and over.
Right, okay.
But if you asked a few questions about their age of sexual debut, those coming into the study,
I see,
and who they first had sex with,
yes, of course,
and how they first had sex, how the contact was made,
yes.
It may be important information that drives change later on.
Okay, yeah. Right, okay.
Our neighbors up north at University of Connecticut are very fond of the IMB theory and technique to try to get people engaged in their own prevention, a buy-in. They've had some success. The Caprisa 04 vaginal microbicide trial was not going well, and Jeff Fisher and others went and helped Bill Creams and eventually had a very successful trial. My question is, where are we with behavioral science research that actually helps men uptake PrEP, men in the case of MSM, I think I'll focus on them for a moment, and then helps people adhere to PrEP? To me, that's a huge frontier, and I just don't see all that much work. I'm probably not, with my finger on the pulse of the field, and probably there is a lot of work. So I'm wondering, in Malaysia, do you have social behavioral scientists who are really looking for culturally sensitive and innovative approaches to engage men, but honestly, to keep men engaged? Because I think we can spend a lot of effort getting people on PrEP, and then they're not on PrEP in 3 months, and I'm not sure where we are.
So I think in terms of within the PrEP context, if you're specifically talking about that, we're really at the infancy stage. So we haven't really, we're really just about to kick off something. So we haven't even begun to realize the problems associated with adherence, which you may have already demonstrated. So I'm not really able to answer that question. In terms of adherence strategies within the positive population, it's still a struggle. Our viral suppression rates are about, within the setting that I work at, 90%, but are generally associated with specific behavioral characteristics of those who you can sort of predictably predict that they're less likely to adhere. In terms of the number of people looking specifically at that as well outside the PrEP context, very few. I think I only know of Howie, one person looking at that.
We just said, there's one person that I can think of. Howie.
Yeah. Do you have any other answers to that question?
When you asked about the social behavioral approaches, no, it's not going on. There is not a high investment that I can see at the University of Malaya to investigate social behavioral approaches to improving PrEP access and PrEP retention and adherence. There's the Center for Excellence in Research in AIDS, but it just suffered a massive budget cut. And it has primarily focused on treatment interventions, and those treatment interventions have mainly been with substance-using people who inject drugs. MSM historically has been off the radar in Malaysia, and whether it's because of political or religious taboos, I don't think I really have an answer on that, and may not get an answer on it even if we asked. But it seems from the outside looking in, I've been working there for 7 years, so I feel like I have somewhat of
Of course you do.
Finger on the pulse. Behavioral and social interventions aren't as highly valued as biomedical interventions. It's just not seen.
You know what I'm going to say. I mean, people just don't get it.
Yeah.
You can have the best vaccine in the world. If somebody refuses to take it, it's not going to do any good. Best drug in the world, people don't take it, it's not going to do any good. If there's anything we've learned in the HIV field, is that we have to have multimodal interventions, because there is no biomedical intervention that does not have a social mediator. I'm singing the choir, obviously, but it's so essential, because PrEP is a gigantic waste of time if we don't have the strategy to help people stay on it. And we know this is challenging because of our experience with positives and adherence level. If you're getting 90% suppression in Malaysia, that's the best in the world. We were getting 10% in Mozambique and 20% in Zambia. We've improved in Zambia, but Mozambique is still probably about 25%. So wide swaths of the world have trouble keeping people on drug when they're infected with HIV. And the notion that somehow magically we've got this bullet and we're going to shoot it out of our gun and solve the HIV prevention problem, when you still have to take pills every day and now you're not infected. It just drives me nuts.
Yeah.
Speaking objectively as a scientist.
The social behavioral component, if I may, at CIRA, which is their Center for Excellence in AIDS Research, is undervalued. There is one investigator doing work, Howie Lim, who was a former NIDA fellow and was here at Yale for a couple of years. You all may remember Howie. And he is the behavioral interventionist there trying to spearhead it, his work. So hopefully that'll change in the future.
And I think Jeff will be looking at some, won't you, in the near
We
future?
will, yeah. We'll continue to look at it among transgender women.
Well, once again, thank you to both our speakers.
Hi. Of course we do.
I'll look into what
Can we do
Yeah. I have my MBChB. Camera. Yeah.
You go to our office.
It's been in the works for